to our program. Our didactic presenter today is Dr. Elizabeth Wassenaar. Dr. Wassenaar is the Regional Medical Director for the Mountain and West Regions at Eating Recovery Center and Pathlight Behavioral Health. And she's also a clinical instructor at the University of Colorado Anschutz Medical Campus. She's a board certified in adult psychiatry, child and adolescent psychiatry, and obesity medicine, and has also completed triple board training at Cincinnati Children's and the University of Cincinnati in pediatrics, adult psychiatry, and child and adolescent psychiatry. So as you can tell, she's a real overachiever. Thank you for being with us here today, Dr. Wassenaar, and we'll turn it over to you so that we can listen to what you have to share with us today.
Thank you so very much. I am coming to you from Denver, where it is not snowing. So I thank you for having me. Let me share my screen. I'm excited to talk about this topic with you all. And I can imagine that you all, there we go, know how prevalent eating disorders and trauma co-occurring are and how confounding of an issue it can be. So we are going to jump right in and do a quick deep dive into what we know about treating trauma in patients who have eating disorders. As well as look at how trauma impacts the brain and talk about how we can treatment plan for patients who have these co-occurring difficult disorders. So comorbid diagnoses of PTSD and eating disorders are up to 24% on the data we have collected. I think that, collecting accurate data on the co-occurrence of these disorders can be challenging because they can both present with such difficult symptoms and especially for eating disorders, we know patients are not always extraordinarily forthcoming with their symptoms. And so there may be patients who are in care for trauma treatment who have co-occurring eating disorders that have not been named or diagnosed. In patients who are in higher levels of care, we can see comorbidity numbers upwards of 50%. Many, if not most, eating disorder patients report a lifetime history of interpersonal trauma, and patients with PTSD and eating disorders present a significant treatment challenge. They have more severe eating disorder symptoms, more impairment, and are more likely to not be able to complete treatment than those without co-occurring trauma, particularly for those diagnosed with OSFED or otherwise specified feeding and eating disorders. So let's take a look at trauma. I think most people on this call are, and on this presentation are somewhat familiar with the diagnoses that go along with trauma, but I wanted to just sort of break it down and make sure we're all speaking the same, speaking about the same things when we're talking about this. So trauma is an adverse events that are experienced differently by different people, depending on a number of factors, including age, race, culture, prior experience, genetic predisposition, and degree of social support. Trauma is an almost universal experience of people receiving treatment for mental and substance use disorders, and the need to address trauma is increasingly viewed as an important component of effective behavioral health care services. And that is from SAMHSA over a decade ago. Trauma looks lots of different ways. The DSM-5 diagnosis of post-traumatic stress disorder, about halfway down this page, is a psychiatric disorder that can develop in patients who have experienced time-limited traumatic experiences, but trauma can look a lot of different ways. Primary traumatic stress is the direct exposure to an extreme event that feels life-threatening. And I think one of the important components of developing a trauma disorder is that the event is experienced as extreme and life-threatening to the individual. And so that's why trauma can be somewhat hard to define, because it's not an objective experience necessarily. It is a combination of objective and subjective experience. Secondary traumatic stress is the reaction to events directly experienced by another. And I think that in our work, where we work with families, we also see a tremendous amount of secondary traumatic stress. And it's very important to note that people can carry both primary and secondary traumatic stress. So we can really get this overlay of experiencing something that's threatening to them and experiencing their loved one experiencing a trauma. And those two things can really get enmeshed and create quite a difficult presentation. Vicarious trauma is bearing witness to trauma. For those of us who are in the caring and healing professions, we almost universally experience forms of vicarious trauma in that we are the listeners and the holders of what other people have experienced without being in that system itself. This can lead to compassion fatigue and burnout. And then complex PTSD, to skip over the PTSD diagnosis we defined already, is a chronic trauma that continues or repeats for months or years at a time and results in severe psychological harm that occurs with prolonged repeated trauma and presents with behavioral difficulties, emotional difficulties, cognitive difficulties, interpersonal difficulties, and somatization, or the body experiencing the trauma. There's a couple of tremendous books written about how our bodies experience trauma, including The Body Keeps the Score by Bernard van der Kolk, and Judith Herman has a book called Trauma and Recovery that this quote is actually taken from, which is just one of my cornerstones of how learning about how trauma impacts a person and their body and their system. Both internally and externally. I think it's so important when we think about how trauma is experienced by the people that we take care of. And we certainly can all observe that there are discrete events happening in this world that we live in that are causing people to develop PTSD. And there are also ongoing traumas that people experience that impact their ability to feel psychologically safe. So chronic traumas are often have non-medical factors that affect health outcomes, can be impacted by multiple systemic factors, and are impactful on health trends and individual lived experiences. I did a little bit of background research just looking at the social determinants of health that can often present with lack of access that create a traumatic experience for people, and things like access to education and healthcare, having neighborhoods and built environments that are safe and functional, having economic stability, and having social and community context and support can impact how one experiences adverse events and or be a precipitant or perpetuator of trauma, in that people experience a lack of psychological safety. One of the defining studies in this field was called the Adverse Childhood Experiences Study, which looked at how childhood adverse experiences impact long-term physical and psychological health outcomes. If you can believe it, there was a time when we had to collect data to say that our bad childhood experiences impacted our lifelong lived experience. But I'm so glad that we did, because this data set that they collected continues to give us ground to do more and more research and work on intervening earlier and creating more safety for our children. The Adverse Childhood Experiences Studies collected information on emotional, physical, and sexual abuse, neglect, and family member incarcerations, and looked at 10 factors and how they impacted long-term health outcomes. And this quote from a paper I pulled, I just thought was so pertinent. Adverse childhood experiences and rearing may generate public health burden that could rival or exceed all other root causes. And I think, as for any of us that work with anybody, our goal is to get there earlier. How can we get there before the thing develops? And with eating disorders, I know that we would all be so grateful if there was more prevention, if we had more preventative factors. And so I think that when we look at protecting children from childhood experiences, we may have something that we can think about to help people prevent the physical and psychological harm that can come. Patients with eating disorders have more adverse childhood experiences. And so there are some good literature looking at this particular patient population. In a sample of 1,000+ individuals with eating disorders at higher levels of care, over 71% reported at least one adverse childhood experience. Patients with all eating disorder diagnoses endorse higher incidence of sexual abuse, parental divorce, and mental illness in a family member, but are less likely to report intimate partner violence in incarcerated family members. In patients, compared to patients with anorexia nervosa restricting type, patients with binge eating disorder are more likely to fall into a profile of patients characterized by high levels of emotional and physical adverse childhood experiences. And compared to patients with anorexia nervosa restricting type, patients with OSFED are more likely to fall into the profile characterized with high levels of household dysfunction. And I just thought that this data set was so interesting because as we work with people with different eating disorder presentations, it can give us some cues and reminders to think about the kind of trauma and the kind of things that they are carrying with them into treatment. One of my populations of specific interest is patients who struggle with compulsive eating and thinking about how adverse childhood experiences impact them and thinking about food insecurity. And I know that that is pertinent across our country right now, but especially in communities and places in the world where there are less resources. When I was in Alaska, when I was so grateful to visit this summer, and I had an opportunity to talk to people who are doing work in the far reaches, I was just really thinking about how food insecurity is likely a thing that is just ever present. And so there's this food security rating that looks from no food security to very low food security, where people are skipping meals and have resource hunger. And there's good data to support that food insecurity has long-term impact on eating patterns, and that there are cycles of restriction and binging coincident with access and restriction to food that are persistent even after people have access to consistent food. So when people grow up in an environment where they have to be resource limited and then they have to take in food, their body learns how to repeat those patterns, and this can persist 5 years after they have access to consistent food. In a study looking at a group of adolescents from Minnesota. Weight stigma. I could spend a whole separate time talking about the impact of weight stigma and how weight stigma is a complex trauma that impacts each one of us, but especially patients who are vulnerable to developing eating disorders. Weight stigma is a form of complex trauma. It is a psychological stress that you cannot escape from. Weight discrimination, stigma, and bullying can trigger disordered eating behaviors, and in fact are reinforced by our culture. Disordered eating behaviors are reinforced by our culture that is so diet-minded. Weight discrimination increases cortisol levels and oxidative stress independent of weight. Patients with diagnoses of trauma and binge eating disorder are more likely to have suicide attempts, and as I said previously, patients with PTSD and eating disorders have more severe eating disorder pathologies and premature terminations from treatment than those without co-occurring disorders. And I think it's very important for us to think about the impact of weight stigma on helping our patients with eating disorders remain in care. That many patients experience a number of factors that can be barriers to them seeking and receiving care, and weight stigma is a tremendous barrier to seeking, receiving, and completing treatment. So trauma changes our brain. And I think that this is something that, again, it's like, it's obvious when you say it, but I think it can be such an important thing to remind ourselves and remind our patients that when you have experienced a trauma, your brain will change and will become, changed in reflect of that trauma. So our biology is shaped by our perception. So the reaction to threat shapes the brain's ability to experience the world. Early exposures to threat unbalance the sympathetic and parasympathetic nervous systems and increase adrenergic activity, which is the epinephrine, the get up and go, the protect yourself, fight or flight part of your nervous system. And what this looks like is people who are keyed up, on edge, reactive, hypervigilant, restless, and irritable. It also diverts resources from homeostatic function. So it prioritizes staying alive with resting. In in order to digest food, your body actually has to be in a relative state of rest. The body doesn't actually feel hungry or digest food when you're trying to run away from that tiger. So in order to actually have homeostatic drive, which is oftentimes tied to metabolism and eating and digesting and resting, your body has to be able to rest. And so people who have experienced chronic trauma may actually have different experiences of hunger, and their digestive system may be acting differently. It can also be important for us to remember how hard it is for our patients to be in treatment for their eating disorder, and how feeling on edge because you are in treatment for the eating disorder can also disrupt your experience of feeling hungry and digesting food, which can exacerbate the experience of trying to eat what you need to eat in eating disorder treatment. The amygdala, which is the part of the brain that lets us know when we should be afraid, can become conditioned to fear. It is the part of the brain that's supposed to be reactive to danger, so it's doing its job. But when it's exposed to trauma chronically over time, it will become overactivated and overgeneralized. So then it will start to experience danger in everything. And I think we've probably all seen patients like that who nothing is safe, nowhere is safe. Their ability to perceive safety has become so muted because their amygdala has been so overstimulated by what they've experienced. The hippocampus, which is the part of the brain that develops context-specific memory or memories, memories in context so that we remember how to respond to certain things, actually is found to have decreased volume in people who have a history of trauma and are in experiences of perpetuated trauma, which can lower the verbal memory scores. So, many times when we're working with patients with trauma, even people who are very well spoken, when it comes to the trauma, their words just evaporate. And there's actually neurobiologic data to show that the part of their brain that's supposed to be able to help them find the language to discuss things is actually smaller. And then the prefrontal cortex, the part of the brain that we all rely on to help us make good decisions, evaluate risk and reward. In people who have experienced trauma, it will be overloaded by the limbic system, the part of the brain that says danger, 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 and defeats its ability to engage in subtle discrimination, learning, and problem solving. And what this presents with is difficulties with sustained attention, mental manipulation, and acquisition of new information, as well as what's called errors of commission. So that's where on those sort of tests where you're supposed to only hit the button when it's red and not when it's green, people who have under-functioning prefrontal cortexes because of trauma will just hit that button all the time and not be able to sustain attention. And so again, we see people who have hypervigilance, overreactivity, and difficulties with engaging with new information. And the way this can present with our patients with trauma is that they're not able to adequately assess their true safety in the present. And so many patients with trauma, when their trauma is activated, which it can be activated when they're in eating disorder treatment, have a really hard time engaging with you with clear and present information rather than sort of bringing in all of the information from the past. So the way that we see this in our patients who have eating disorders is that when they are in their eating disorder or seeking eating disorder treatment, the trauma brain can be really reactive and overreactive. It's important to remember that the eating disorder may have mitigated their trauma experience. And one of the things that I really like to remind people is when they're sitting in front of me today, they are here today because they survived a whole bunch of stuff to get here today. And I want to have gratitude to the parts of them that figured out how to survive and also help them to make a decision about which parts need to go forward. So I think that it's so important to remind people that that eating disorder, even though it's killing you now, it may have helped you survive something that was completely unsurvivable when you were a child. And we can find ways to notice how that eating disorder feels like it should still be serving you, but it is no longer. Also, a malnourished brain can blunt the fight or flight response, so that feeling on edge may be less when you're very malnourished. Focusing on food, calories, and body size distract you from trauma that's outside of your control. And then the eating disorder behaviors often have a component of dissociation. So whether it's restriction, binging, or purging, or exercise, or using diuretics or laxatives, all of those have a way of taking you outside of the experience of the present. And then many, many survivors feel that if they can just change their body or keep themselves smaller, that they protect themselves from being victims again. A lot of there's historic belief that you can't work with trauma and eating disorders at the same time, that working with them at the same time is a destabilizing experience or destabilizing process. And sometimes people get focused on what's primary. Is the eating disorder primary? Is the trauma primary? Is the substance abuse primary? I think it's important, and I want to challenge all of us to think about treating the whole person in front of us and prioritizing with them and engaging them in treatment planning and how they'd like to move forward, thinking about everything that's going on. It can help us build our own compassion and resilience for the way trauma can present in patients with eating disorders. When we think about that, what can be traditionally labeled as treatment interfering behaviors may actually be, again, behaviors that were trying to help someone survive something that felt unsurvivable. And so thinking about how self-injury can discharge somatic tension, how suicidal thoughts can overcome feelings of helplessness, how high-risk behaviors can activate the adrenaline response and combat that numbness and dissociation. Reenactment can tell a story that the words can't find. Caretaking of others can combat a sense of worthlessness. Addictive behaviors can manage trauma symptoms with different types of dissociation. And then the dissociation itself can protect from experiences that cannot be fully emotionally experienced currently. It doesn't mean that any one of these things is serving them to live their most healthy and recovered life, but I think that helping people to find compassion and helping yourself to find that compassion can be really helpful as you work with these difficult symptoms. There are many treatment approaches to the treatment of trauma. I'm aware of the time, so I'm going to really look through these and make sure that you can see them, and we'll cover them in the questions. So important to remember hierarchy of needs. Safety and stability is first. Establishing a therapeutic relationship and working on therapeutic or self-regulation and relaxation and taking care of oneself. Cognitive processing therapy is an evidence-based, trauma-focused form of cognitive behavioral therapy that significantly reduces the symptoms of PTSD and is founded on 3 principles: avoiding avoidance and identifying stuck points and using Socratic questioning. It does not rely on the retelling of trauma narratives. And I have seen CPT used in patients with eating disorders many, many times, and I really like that it doesn't rely on somebody having to sort of do a retelling of their trauma narrative, but can find meaning making in the trauma work. For younger kids, thinking about trauma-focused cognitive behavioral therapy has a tremendous amount of research and support, and involves caregivers, which is so important in any kind of trauma work. So to wrap it up, untreated trauma symptoms can maintain and trigger relapse of eating disorders. Trauma treatment can co-occur with eating disorder treatment. Never forget the way that weight stigma and internalized weight biases contribute and maintain traumatic experiences in the development and maintenance of an eating disorder. And there is good research to support that we can do integrated treatment. All right, I'm going to stop sharing my screen. Maybe.
Wow, that was fantastic. It really is. We're getting lots of good positive feedback in the chat, and also some questions. So I'm going to start with some of the questions that have been included in the chat, but also if you have a question, I would encourage you to use the raise hand icon and unmute yourself when called upon. So the first question asks, So it seems that the impact of trauma on the brain and body overlaps significantly with the impacts of malnutrition on the brain and the body. So, how can we, as providers, support patients in understanding this overlap and the importance of both restoring nutrition and engaging in the behavioral support for trauma?
Yeah, you're absolutely right. Trauma is a stressor to the brain, malnutrition is a stressor to the brain, and it is, full recovery requires addressing both. And so I do think that it is important to, one, assess with your patient if they understand how the trauma and the eating disorder are working together and working against them, working against the life that they want to live. And then, my experience with working with patients with both of these co-occurring disorders is many patients with eating disorders are very motivated to do trauma work. They really want to do the trauma work. They want to resolve the trauma. And so I will talk to them about how feeding themselves is trauma work. And so part of my role with them is to help them ground themselves in safety and stay present while they care for their body. That is one of the most powerful pieces of trauma work we can give any one of our patients. And if they can stay present and care for their body, they are doing graduate level trauma work. So when I frame it that way, I do find that I can get more buy-in.
Fantastic. So I have a question. So you talked about the trauma's connection, and sometimes this trauma can be related to things that have happened in a family unit. How do we then manage this while at the same time wanting to make sure that we're not parent blaming with parents who often are feeling a lot of guilt or shame or wondering whether they caused this? And we know that those feelings can kind of discourage parents being involved and taking charge in the treatment process. So, do you have any good recommendations for how we can acknowledge that sometimes this is the case, and yet we also want to make sure that we're not parent blaming and getting parents and families involved in the treatment?
Yeah, so I remind my families that I truly believe that everyone does the best that they can with the resources they have in that moment. And that as we know better, we do better. And so, I think that it's important when we're working with families to also have some space that can be separate so that you can have conversations with the parents and maybe talk to them and provide them emotional support around experiences that were either objectively or subjectively experienced by their loved one as a traumatic experience. I think that the reality is that parent-child relationship is very complicated, and there is not one parent-child relationship that doesn't have some history of whether it be sort of um, routine mismatch or really catastrophic mismatch. And so creating a place where the parents can safely acknowledge, talk with you about what happened, see where they're at with their ability to take ownership, grieve. And then if you have a parent that is just really in really significant denial about a thing, and you can see it, and the kid wants to talk about it, or your young adult wants to talk about it, and the parent can't receive it, I think that this is where it can, part of the family work can be that providing emotional support for someone does not necessarily mean you 100% agree with what they're saying. You can validate someone's experience and have your own experience of it. And so really helping the parent and child to hold separate mindedness, but providing support for both. And sometimes in those really challenging situations, it's important for you to phone a friend and get another family therapist involved or someone that may be able to hold that family system with you because the dynamics are so complex.
Thank you. We have time for one or two more questions. If anyone has one, then feel free to enter it into the chat, or also feel free to raise your hand and unmute yourself. No such thing as a dumb question.
I see Katie put in something about emotion-focused family therapy. You are right, Katie. EFFT is just a foundational work that I reference most days, almost every day, many times a day. I think it is such a great process. It really also relies on the idea that parents are trying their best and that parents want to be their child's advocate, and they want to support their child towards health, and they may not know the best way to do that. So it's a process, it's a manualized process that's accessible for all of us doing the work. There's good training programs available, and I find it to be a tremendous resource.
Mm-hmm. Wonderful. Any more questions? We have time for one more.
Oh, there's one in the chat.
Yes. So yeah, go ahead, Katie.
Yeah, Tommy writes, would love to hear more about malnutrition and trauma and how starvation influences trauma responses. So maybe a couple more minutes.
Yeah, that's such a good question. Thank you for that. So we have to remember that a starved brain is already in a state of heightened anxiety. The brain is trying to keep your body alive, and the body does not want to starve. So when a brain is malnourished, it creates an environment where things are likely to be felt more intensely. And I think most of us who work with eating disorder patients can resonate that when our patients are pretty malnourished, experiences can be more intense. And so I think that it's important to just recognize that starvation is likely to lessen the emotional bandwidth and resilience that your individual, the person you're working with, might have at baseline when they are more well nourished.
Wonderful. Well, thank you, Dr. Wassenaar. We're so glad for this opportunity to at least start to discuss this issue of trauma and eating disorders, which we know is so prevalent. There's a lot more to be done, but we're really glad that we got this opportunity to start out.